How about now, guys? These are like interpretive, like.
Oh, now.
We got you.
All right, wonderful. Yay. All right. So you guys were watching on the screen, but the point here is that we found a unconscious person choking at dinner that we found to be hypoxic, tried to assist with ventilations, took the King vision out so we could do a direct, actually a video visualization of the airway, saw a big old hunk of steak and got the McGills out to relieve the obstruction. So now we're looking at the protocol. And this patient really kind of falls between two kind of broad categories of patients that the protocol really identifies, which is that alert patient who's given the universal sign for choking, that in our protocol, we could still actually give like a Heimlich and try to relieve it. If they truly are unconscious, which this patient is like definitely altered in agonal respirations, is probably more this patient than the alert patient who's like kind of doing this. Then we actually start chest compressions. And part of that actually is to basically do like the Heimlich. Even if they do have a pulse per se, you can actually give that forced chest thrusts to try to relieve that obstruction that way. That said, I 100% agree and like the pathway that the crews did in this situation, which is just go take a look. Do your laryngoscopy. If you want to do it with a King, even better. If you're able to get in and kind of visualize, really on the ball thinking to get that McGill forceps out and see if you can really do something. And that's kind of what the rest of that protocol says. At the end of it, it really does say, consider crike and needle crikes and these sort of things. That's pretty far down, but of course that's all part of this too. That's going to be potentially a little bit more technically challenging as someone with a history of head and neck cancer, especially if they've had radiation. But that is something to consider as well. So just a quick review on the McGill's forceps. If you haven't pulled it out recently, please do, but they are a really good tool. I really like the McGill's. I've used it several times. The only thing with the McGill's, which I will highlight here, is the proper hand positioning and usage. I'm not even going to kind of say some alternate ways of doing it, but the way that it's kind of pictured here is the proper way to do it. So you kind of have your hand above with kind of the opening basically to the side of the head. And so it gets entered in using kind of this trajectory. And the reason being is that at the end, and I'll zoom in here in a second, but at the end of it is kind of this really rounded out area. And that area right here is meant to follow the posterior oropharynx kind of all the way down to the level of the cords. So if you kind of like follow that trajectory down, then you know that you're going to be picking it up rather than kind of like shoving it in some other way that doesn't utilize kind of this very blunt, rounded edge to help you bring down. So if you end up using it in a position like this, where you kind of have your hands off to the side, your fingers kind of come into the top, you're kind of looking with your VL or DL, and then kind of coming in and just kind of swooping it this way, kind of pulling up this way. They were actually, the McGill forceps were actually originally designed to assist with intubation for head and neck cancer patients. This is like kind of the original description of it. And so actually, you could actually use it in this way. I never have. I'm marginally interested to try. But if you kind of think about it in this, for this original intended purpose, you can help kind of think about the geometry and the proper positioning of kind of how the end of it comes in. But basically, it really was like head and neck cancer, head and neck surgery patients, especially with anterior airways. You can slide that McGill's in, grab the tip of the endotracheal tube, and then with the McGill's, you can just kind of like slide it up. And that was actually the original intent of those McGill forceps. But they're obviously quite handy and really most commonly used the way that we use it. So really nice job reaching for those McGill's in that way. Here's what actually happened to the patient. So was pretty moribund in the emergency department, very similar to what you guys saw on scene. So it was still hypoxic. And so what they actually ended up doing, which was kind of interesting, but ended up doing the trick, which was they put a bunch of high flow nasal cannula oxygen in addition to bag valve masking. So they were kind of doing some apneic oxygenation in that situation. And then it sounds like what they ended up doing is they wanted to take another look to see if there's anything left with basically an endotracheal intubation setup ready to go. So what they did was what they called just like delayed sequence intubation, essentially, or essentially they gave ketamine for like sedation purposes. So they could go in, take a look, and see what they found. And when they did that, actually, lo and behold, they saw more hunks of steak, which they pulled out, again, using the McGill's forceps. And then at that point, their plan was to intubate the patient. They had to give, they couldn't quite pass the tube just with the ketamine. So this is another reason why we don't do like just sedation facilitated intubation. And that wasn't necessarily their plan going in, but they were like, hey, you know what, we're here, we can intubate, let's give it a shot. They're like, this is not happening, pull back, bagged them up, did a true RSI, then intubated the patient. And in the course of that, they actually had a little bit of evidence they were able to suction. So this patient actually did remarkably well, especially for the duration of hypoxia, really a challenging airway. But essentially, like later that day or the next morning, once the sedation kind of wore off from the endotracheal intubation, they lightened up the propofol sedation, and the patient was like starting to pull the tubes and was extubated. We watched him for an extra day, but ended up going home. So that was actually a very positive outcome with what was a period of hypoxia, but a really nice job in terms of relieving that airway. I think we probably do have a couple areas of improvement, but what I will say is at the end of the day, and what I want you to take out of this is airway obstruction. Take a look, get those McGills out, get that obstruction out of the way. If we know though that we're dealing with a true airway obstruction, and like this story is a pretty good story for it, like you sitting there eating dinner and then all of a sudden couldn't breathe. That oral airway, the OPA, it's probably not going to get you anything. And two, it might actually push like a food bolus that's sitting right there down even further. So you might actually be complicating the situation, making it harder on yourself. So if you end up in that kind of situation, if you really want some like airway adjunct, I would probably think about like an MPA. But to be honest, like once they become unconscious, then that whole oral pharynx kind of loosens up a little bit. Take your look, see what you got, and then just move to your laryngoscope and your McGill.
They mention a language barrier at all? Did family not tell them that, hey, he's choking, or?
No, they did not mention that. I don't get the sense from anything in the chart that would have suggested that. I think it was a pretty good sense that they were coming up on scene. But it's a good point, right? And so, you know, with that in mind, like if it's undifferentiated, like just found down, 100%, I'm with you on that. I think I got the sense it was probably a pretty clear choking. The other opportunity, and honestly, this is kind of acknowledging all considerations top to bottom, but with that period of hypoxia, and we're already seeing that reflected in bradycardia, if we're able to move up any of those attempts higher up, even if it's like a look and see into the oral pharynx, and we can kind of move something out of the way. I would have liked to see that, but I also acknowledge that, you know, we have limitations on scene, and if you're not going to get any kind of view to get what really was a definitive management of this, which is radiolaryngoscopy in the gills, they're on scene, then it is what it is. But if you think you're able to bring that to the scene rather than, you know, what could be 5 or even 10 minutes moving downstairs, and then you have all that period of hypoxia there. And then we have that period of decline as well. So all in all, very nice job on that. We, you know, potentially have some areas there, but nice job bringing out the McGills. Nice job. All right, any questions, comments, concerns on that first case? All right, we'll move on to the second. All right, so this is a sudden onset respiratory difficulty breathing. This is a lady who actually had recent femur fracture. She was actually rehabbing and then suddenly had difficulty breathing. She actually was kind of working with folks, and they actually tried a couple things in advance. So I think it might actually be a male, but a couple things that we learned. So one is it was kind of sudden onset during the rehab session. Two is that we're getting a sense that maybe this person has been experiencing some aspiration episodes. had tried to drink water, had some choking periods. And then the kind of the medical providers at the scene were actually doing some stuff right. So the patient actually was supposed to be on oxygen at baseline. Maybe wasn't on it, maybe was, who knows, but in the event they increased the oxygen above whatever baseline the patient was supposed to be on. And they started doing some nebulizer treatments, history of COPD. Now that wasn't working, the patient was kind of going downhill. When we got there, actually the patient was obtunded, although the sats were okay, but that was a little bit after some supplemental oxygen on our part. The mental status started to deteriorate. And we then were like, all right, let's just start bagging the patient, which is a great idea. And here's kind of where I want to kind of highlight some really nice things that were done. So when we saw this progression, started with respiratory distress initially, some interventions were not correcting it. Patient became limp, started checking a pulse. Turns out there was a pulse, but we're like, this patient is perico, they're going to rest. So put those pads on, we talked about that 100 times before in terms of anticipating that impending arrest. We do that with STEMI patients. We do that with patients who we see are kind of moving in the wrong direction. And then in addition to that, we got the drug bag out. We're like pretty much got all of our intubation stuff ready to go, ready to coat the patient. We even got the Lucas plate in place. This is awesome. I mean, this is really good. This is like if this patient, basically when this patient starts to code, we have everything ready to go. And that's exactly what we want. But lo and behold, patient actually did okay. And actually with that supplemental oxygen that we were doing, positive pressure with the bag and the supplemental oxygen, the patient actually started perfusing their brain a little bit and actually started following some commands. So we never actually ended up using any of those drugs that we ended up getting ready for, but I'm sure glad that we were in position to do so. Because here's kind of the vital signs, and here's our assessment of really a sick, essentially peri-arrest of what they didn't arrest patient. So you see maybe a relative hypovolemia, definitely a bradycardia, hypoxia to 87%. The sugar is behind the Zoom thing, so you guys online can see it, but for those in the room, it was 240, which is clearly not hypoglycemic. I forget if this patient was diabetic or not, but even if not, that hyperglycemia is more of a reflection of like this patient had a ton of just cortisol circulating in the system. So the body knows that it's sick and it's releasing hormones out to say, hey, let's increase this level of glucose in our system. So it kind of can be a bit of a marker, like we've talked about before, of just someone who's really sick, especially if they don't have a history of diabetes. So this patient, super sick. That's it. We ended up transporting, signed them over into the trauma bay, and away we go. So honestly, not a whole lot to talk formative wise on this case. Like I said, I really like the setting up for peri-arrest, but I kind of want to take that opportunity. If you are in that situation and you think the patient's about to arrest, then remember you do have the option for push dose epi, and that could have been a potential opportunity. The blood pressure of 104, isn't like an absolute, this is hypotensive, but maybe in someone who has a history of hypertension and who is moving in that direction, that might be one of those drugs you might want to draw up. So I just want to take this opportunity to kind of review push dose epi. Here's kind of our protocol and kind of what we say about it. So a couple things. So one, not all hypotension is shock. Not all hypotension needs to be treated, but it really is when you think about shock and decreased perfusion, then you start thinking about end organ stuff. And so you think about, yes, vital signs, but then you also think about
or seizure, Wendy's, D342, Princeton, Glendale, cross rate of brace, ESD 409 at 13.3.
But that level of consciousness, that end organ, that mental status is a huge marker. All right, so ultimately, when you want to use push dose epi, what you want to end up having is a solution that is 10 micrograms per ml.
We had a 2-year-old female that was in a seizure. She is alert and conscious at this time, talking in a black Honda minivan. she has been sick lately.
I will say that that is also a theme, which I don't have to tell you guys, but it's the febrile seizure. Now that we're pulling all these speed runs for that. All right, so that 10 mics per ml solution, and this is, you were told that there would be no math, there is math in today's QI. But that 10 mics per ml is the same as 0.01 milligram per ml. That's just math. That is 0.1 milligrams per ml divided by 10, 0.01 mgs. So that is your code epi, which again is 0.1 mgs per ml. The whole milligram of that 10 cc syringe that comes in it, but it's 0.1 mgs per ml, and that's kind of how you get there. So what you want to do is basically just divide this volume by 10. The first way that the protocol says, and honestly, I'd probably just be familiar with one way to do it, although keep it in your back pocket. This is usually the kind of the easiest way, is that if you just have a 10 cc syringe, have 9 mLs of saline in it, draw up 1 milliliter of that code dose epi, and you have 10 ml, but you have your 10 micrograms per ml. So you've essentially done our math here, which is that 0.1 mgs per ml, that code dose epi concentration, divided it by 10 by having a whole 10 cc syringe for that same amount of epinephrine. And then you just give the dose of 2 to 5 mics per dose. Here's the other way to do it. You could do it into a 100 cc bag as well. Again, you just want to divide by 10. And so if you end up using the code dose epi, then you take out 10 cc's and then just put in the whole stick into the 100 cc bag. If you want to use the anaphylaxis, the IM concentration of epinephrine, then you just put a ml of that into the bag. That extra 101 ml of the math is the same, right? So those are the other two ways to do it. You can do it with a bag or you can do it with a stick. I think it's probably just easiest to do it with a stick, but whatever. But ultimately, as long as you're getting to that 0.1 milligrams per ml, then you can kind of start giving your half cc to 2 cc mLs every couple minutes and titrate to effect. It's actually really good. There are a couple good bradycardic patients here today. It's actually a really good med to use in the context of like symptomatic bradycardia too. So if you've already kind of thought about atropine, you thought about pacing, push dose epi, as long as you have room on the blood pressure, especially if you have room on the blood pressure, push dose epi is actually a really good option. All right, so how did this patient do? Well, they actually did really well once they got on BiPAP and got that reliable supplemental oxygen in place. I will tell you that, you know, when you look at a case where like recent femur fracture and sudden onset respiratory decline, you got to think about pulmonary embolism. That was the first thing on my list when I heard about that. That was the first thing that the ED did. They like sent it straight to scanner because they assumed that that's what they were dealing with. Turns out not. You actually can have, and this is actually like not like in a rehabilitating from a femur fracture kind of thing. You can actually also have fat emboli as well. So on those really long bone fractures, you can actually get like little fat globules to go up. Not only from the pulmonary aspect, but can cause like kind of pretty bad stroke as well. While there probably is like a little bit of like local blockage from the fat globule, what's probably more driving that is just like this really bad inflammatory response. If it goes to the brain, actually people can like recover okay, but like that would be another like way outside thing to consider, mostly in like the, you know, I broke my femur like a couple hours ago kind of thing. So, but anyway, so no PE. It did show aspiration pneumonitis, and so probably what was going on is the patient was aspirating, you know, repeatedly, and it eventually just caught up with them, gave them hypoxic because of it. We also found they had a urinary tract infection, maybe not super uncommon, and so basically they just like threw broad spectrum antibiotics, admitted them, and then right before they went to the ICU, became hypotensive again, get on multiple pressors, and at that point the patient continued to decline, just was not turning the corner over the next, like, I think, day or so. And so the family decided to focus on comfort rather than that. But it was a, you know, in this situation, I think it was a really good case of correcting what we can and actually seeing a response, but most importantly, getting ready for really what was probably the most likely thing, which is that patient arresting and being ready for if and when it happened. But nice job temporizing. All right, any questions, comments, concerns on that one? Nice job. All right, so this next case 3, the narrative is pretty straightforward. I think it was an older person who pretty much lost balance, fell to the ground, hit their head and injured their wrist. Now this consciousness was GCS 15 interactive. Great job getting some fentanyl along the way for patient comfort. We monitored the patient the whole way. We've give a report. Here's what I want to kind of talk about, and which is what is documented as a super thorough physical exam, which ends up being kind of all these check boxes that come in. And so we go all the way from airways, eyes, each individual toe was assessed as normal. Thank you. Wrist, the right toes now are sacrum. We took a look at ears, genitalia, heart, all periumbilic. This is a lot of physical exam, and not to say that all of this didn't happen, but this would be a super complete physical exam for this patient to have had. Which, if you're going to do it, then fine. But if it's documented, remember, we got to trust that you're doing that whole exam. I actually had a resident back many years ago who he was like an ankle sprain. I actually took a look at his note. He was like documenting, like looking inside the ears and all the rest. I was like, you clearly did not do this. And he was like, I don't know. Maybe I did. Maybe I did on all my patients for the practice. I'm like, all right. But even if this was truly the exam that we did on scene, which again is documented, so I'll trust that it is, there are clear discrepancies in this whole long list of toe by toe exam versus what is documented in the narrative and elsewhere. So first off is the wrist. And so there's both a visible deformity, and we actually assess it as potential fracture compared to what's documented as a normal right wrist. There is a laceration above the right eye, and whether you call it the face or the head doesn't really matter, but both of them were listed as normal in that big long list. And while not to be kind of like normative in my thinking, the genitalia was assessed on that big long list of exam, and it was assessed to be normal. And in fact, there was an indwelling Foley catheter, which again, I don't want to be normative in my assumptions, but it's probably worth noting above and beyond normal if you're going to be taking a look at the genitalia. So this is all to say that, again, can't say one way or the other, but when you have discrepancies in different parts of your notes about the same thing, it does call into question the validity and reliability of everything else that's documented there, right? And so someone's going to pull up the narrative, someone's going to pull up still the same chart, still all the documentation, still all your writing that's in there, and then that reconciliation is going to be tough. This case is not a big deal. It's not a big deal in this case, but at some point it will. Here, go ahead. Is someone chiming in? No? All right. So, that's learning point number 1. Careful of your dot phrases, your pull forwards, your copies and pastes, or making sure that your exam findings are reconciled in different places once you do. The other part here that I want to talk about a little bit is quick discussion on types of fractures. I will say, back when I was an EMT, I was very hesitant about putting like diagnoses in the chart. And I think if you limited to say like there was a obvious deformity of the wrist, I think that from your perspective, that's totally fine. I mean, I can take a look at something, we can all take a look at something and say, yeah, that's probably a fracture. It's hard to say that for sure. And I get hesitant, like in writing my documentation, like without like an x-ray to kind of say for sure, unless I'm like literally saying, so it's really right. But I'll usually say deformity or something like that. But I do want to say that when it comes to types of fractures, closed fractures versus open fractures, there is some subtlety there. And in fact, when the patient got there and they got everything cleaned off and irrigated and get everything looking, there was a little bit of just the smallest little thing that was oozing blood right where that fracture was. And that actually is an open fracture. So when we think about open fractures, we think about this, right? This is like bone sticking through, we can see the end. By no means is this the end all and be all of open fractures though. Open fracture, also called compound fracture, is anytime that the bone breaks the skin in any way. Usually we think about long bones like this, and usually we think about it as dramatic, but it has a range. And in fact, like in this situation, this patient was closer to this, I forget the two guys' names, Anderson, I think was the second name, but it doesn't really matter. But sometimes it can just be that really quick, boop, hitting outside and then kind of coming back in the spot where all you're going to see is just like a little, and actually this class 1 is specifically defined as less than a centimeter. And so you have this whole class of like open fracture, it's a less than 1 centimeter break in the skin. Then it goes up, and obviously this is stuff that we're not going to miss, but this we have to be really attentive to. And sometimes it can even look like a small little abrasion over that site. Turns out actually this was end up being kind of one of the focuses of the patient's admission was this, what was called an open fracture. Now, they did not go to surgery. They very well could have to wash it out and do all that. They ended up kind of treating conservatively. They did antibiotics. The patient did fine. But just to kind of highlight, not all open fractures are that bone sticking through. And so if you see any kind of change in the skin, abrasion or otherwise, at least kind of reporting that forward in one way or the other is a good thing to do. I will say that I also tend to overcall these. Sometimes, if you have like a deformed ankle and it's going to rub on the ground, you have a little bit of rug burn or something like that. I end up at least usually having a conversation with, the orthopedic doctor or something like that and say like, hey, like, here's where the deformity is. If the skin looks intact, we're all pretty comfortable with this not being an open fracture, right? Or if there's like a little, even if it's a cut, you can see the base, I'll have that same conversation and we'll see. But it can potentially change course of action. All right, so that was that case. Any questions, comments, concerns on?
I've got a question.
Yeah.
Section.
Yeah.
How does that happen in PCR?
So that run has actually been sitting there in reroute status to that crew member since this has been submitted.
Well, okay. Or to select all those fields, is that
Where is
under?
It's under when you go to the body survey, you can
Okay.
go through and select every individual.
Is there a way that it automatically cues it as all normal? Because that seems like 15 minutes of work that nobody would.
No, on that one, there's not. The only one that can do the all normal is when you're doing the normal assessment field, and it's the within normal limits button.
Yeah.
That's a manual touch on each one of those.
Oh, Jesus.
All right, this is a bummer of a case. This will be a little bit quick one, but this is a really good decision making on the crew's part. So this is got called out as a sick person with a headache. We learned that the patient had what turned out to be an ischemic stroke in their cerebellum about a month prior. Was at work and started feeling kind of bad, started having a headache, wasn't feeling great. Was talking with us. We kind of did our usual exam, nothing like super exciting. Started putting the patient in the cot to kind of start moving out. And then she kind of started having a really pretty rapid deterioration in her mental status. To the point where she was probably still like able to talk, like her speech was incomprehensible. She actually developed focal neurological findings right in front of us. We were worried that something was happening and something was happening quick. So initially, whether that was brought up by the sister or whether you guys talked about going directly to a comprehensive stroke center downtown, that was certainly in the ether, and it sounds like we were probably moving in that direction. I don't know if she was trying to help patient or not, but we were we at least had the conversation about going to a comprehensive. However, when we started seeing this very rapid decline, especially potentially concerns for airways and all the rest, we were like, no, we're going to the closest hospital, which is exactly what we did, pulled off, go to Westchester. And here is why your decision-making was validated. So this is acute hemorrhagic version of an ischemic stroke. This is worsening bleeding. So the blood, so this is all this white stuff, that's all bone. So that's all that bone, that skull around the cerebellum, very small amount of room to swell if blood is going to happen in there. And this is a huge, like 2-inch by 2-inch hematoma in the cerebellum. So there's a large, very large bleeding. This is why, as you can imagine, I'll kind of show you what happened in the emergency department, is that she was initially kind of talking again, kind of incomprehensible, wasn't really, but was alert. It was hypertensive, got to the CT, basically when she got back from the CT, continued to have rapid neurological decline to the point where they needed to intubate her. They tried blood pressure control, tried all the things. They did send her down to UC, but at that point it was, she was already herniating, and it was, the family decided to focus on comfort for her as well. But when you have this situation of kind of rapidly accumulating blood, really anywhere, but especially in that posterior fossa, you have brainstem right there, and so you're very rapidly going to lose your breathing, your brainstem reflexes, your breathing abilities, et cetera, et cetera. And so very astutely, you guys were already picking up on some sort of acute neurological process, probably stroke. We were thinking in that direction, a little bit above and beyond kind of what our just, basic assessment would be, right? So this is like severe headache and someone who's had a stroke recently. So we're already thinking about that. We're beyond our protocols. We're thinking like the highly trained folks that we are. And then when we saw this, then we're thinking, all right, mental status change. Let's go and get this checked out. So really nice job on that one. And unfortunately, she ended up succumbing, but nice job in bypassing that situation. Questions, comments, concerns about that? All right, let's see what case 5 is. All right, so this is a cardiac arrest. I think our next 2 are cardiac arrests. But shout out to police. This is one of our law enforcement officers who was really kind of helping us out, was doing compressions when we got there. And actually, I know a couple of them are EMTs, or at least were in former lives. And so actually they were helping out with bag valve masking. So good on them. Thanks, PD. We saw asystole. So we're going down the PEA asystole protocol. I don't like too much that we couldn't get a capnography even with the second one in place, but we'll table that for now. We'll talk about that more, or have talked about in the past. We did appropriately check finger stick blood glucose and treated appropriately with D10, so nice job. For this patient with undifferentiated history, we ended up giving epi, bicarb, and calcium. Did a full, even above and beyond 30 minutes, 37 minutes. Was not having any change in status and the calling for termination. So I just want to talk a little bit about medications in the context of cardiac arrest and kind of what our protocols say and not, because we've seen this the last couple months, if not more, about kind of this creep into the bicarbs and the calciums for undifferentiated cardiac arrest. I just want to kind of bring us back to kind of what our protocols say about it. And that is really, if you are dealing with an undifferentiated PEA arrest, really our medication is epi. Now, if you are in a situation where you're running this arrest at the Vita or something like that, and you're thinking that this could be a hyperkalemic arrest, well, by all means, yes, go ahead, do your calciums, do your bicarbs. If you think this is a potential overdose, go ahead with your bicarbs. Those are good situations where you can narrow the QRS. Hypovolemic, pneumothorax. So you have some targeted management, but for the truly undifferentiated arrest, the protocols don't have bicarb, don't have calcium in the routine use for PEA asystole. And that's actually rooted in AHA recommendations. So you kind of go down here, it actually says like confidence or recommendation 3 for like no benefit, calcium, bicarb, mag. Now, again, if you're in that situation where you are at, at dialysis clinic and you have a suspicion for this, you have a crush injury. If you see torsades, we're having a different conversation, but for the undifferentiated arrest, and largely this is based on lack of supportive evidence. Really, if you take a look at it, and again, when we think about cardiac arrest, we want to think about neurologically intact survival, but when we see these medications given, we're not seeing any neurologically intact survival inside of the. So bear that in mind when we actually look at our next case here too, which is case 6, which is another cardiac arrest. So this is another, again, our theme of orthopedic injuries, although peripheral it is. This person recently had a knee replacement again, and then basically had a was found by our physical therapist, pulseless. Again, we got to think about pulmonary embolism in this situation, but so we got called by the physical therapist, by the patient apneic and pulseless about 45 minutes after last known scene. That's normal. We go through our usual ACLS. We do give sodium bicarb again in this situation. Again, for someone who really, I can't see a reason why I would think that they would be in renal failure. Guess you could maybe make a real stretch to say that maybe they were on the ground for a while, but 45 minutes, I don't know if that'd be supportive. So again, just like in our case 5, case 6, we're looking at kind of medications that are not routinely recommended. And part of it, especially if this has ended up being a respiratory arrest primarily. And the reason I think about that is, again, when you have knee replacement and maybe pulmonary embolism, you have obstructive shock, it can lead to respiratory distress. But if you do end up having a true like respiratory arrest and you give sodium bicarb, well, if you have kind of our acid-base formula, if you remember way back in like our paramedic training, you have bicarb on this side. It wants to kind of find this, stable state, but then it's also going to be in equilibrium with carbon dioxide. And so when you give a big bolus, a big wad of bicarb, it is actually going to get the relative levels in the serum are going to go way high for bicarb. And so the body's response is to make this whole system equal, to go into equilibrium. So you're actually going to move from this really high bicarb state, equivalent out eventually, where eventually you're going to try to get everything even. So this actually is going to paradoxically increase your carbon dioxide. And so if you do have a primary respiratory arrest where you're hypercarbic, and you give bicarb on top of that, you're actually going to paradoxically worsen your respiratory acidosis. And so that is yet another reason, at least mechanistically, you can consider as a reason why you don't want to necessarily give bicarb on differentiated ways. All right, so that's the bicarb. Figure stick was a little bit low at 51. I probably would have liked to see D50 or D10 hung in that situation as well, like they did in the previous. 51 is kind of borderline for causing arrest, but it's an H and a T that we can easily correct. And so if we're kind of throwing kitchen sink, may not be a bad thing to select that D10. Knee replacement, like I talked about, we think about all the reasons that we talked about, including PE. Who knows why? We're not going to really change a whole lot based on that. But there was an IO placed, and it was not on the side of the surgery, at least that I could tell. But I do want to take this tangent just to at least talk a little bit about that. In case you do find yourself in a situation, and kind of mostly as a reminder about IOs in the context of people who have had prior knees or shoulder surgeries. So our protocols say that if there has been a prior orthopedic procedure at that site, to consider some sort of alternative. The Easy IO package insert essentially goes a bit further and says that actually a prior orthopedic operation at that area, so a knee replacement, would be a contraindication at that site. And when we teach it, I mean, if you talk to Scott O'Leary, he'll say like, hey, if you see like those scars, like you want to go to another site. our protocols aren't quite as explicit, but I would certainly err on the side, and I would advise you to look for another site rather than going to an area. One is, and I honestly, I tried to look at this, maybe, especially if you guys teach IO training, maybe you know better, but I'm not actually entirely sure how well the delivery is for the IO medications when you have a big old metal rod in place. And actually the metal rods actually go down a fair amount actually into our sites. But here's another reason actually, and someone tried an IO into an area where there was a knee replacement and it dislodged the whole like mechanical knee, and then it got infected, and then the joint got infected, and then once you get like a joint infected, it really can be a real tough course. So for a variety of different reasons, looking for an alternate site is what I would want you to do. Not to, again, not to say that didn't happen in this situation, just an opportunity to kind of review.
Question on, placement of joints and things. If you had like a double hip replacement, you still wouldn't be able to do a IO.
Hips are fine. It's orthopedic, the way it's worded in the package insert, which is exactly the same in our protocol, so I have to imagine someone copied and pasted, which is fine, is pretty much at the site. So it'd be like, if you're doing like a tibial IO, it'd be a knee replacement, humeral head, it'd be a shoulder replacement.
It doesn't matter how long ago the surgery was, it still shouldn't.
They don't specify. They don't specify. And I think part of it is probably related to like that case report and that infection and stuff, because if you end up getting in there, it's a problem. But then the other part, like I said, is, you look at the pictures and stuff, and, the stuff travels through the bone marrow into your circulation. That when they do a knee replacement, they jam a huge metal rod into the bone marrow. So I actually don't know like how well that circulation is. It might be fine. And like I said, if anyone teaches IO stuff and you guys talk about this, then fine. I just conceptually, I'm wondering actually how efficacious that would be if you have a big old metal rod in the middle.
You'll get through the bone, you just won't get through the metal.
Exactly right. And then like how much, I mean, maybe it'll bathe that area around the metal between that potential space between the metal.
You should know something's off.
I would think
I
so.
would think so.
Yeah. And I mean, it's granted, like, especially, as people get older, like those scars do fade. Hopefully you're able to see something. And I mean, if you place it and the scar is super faded and it is what it is. I mean, it is what it is, but yeah, if you see something going on there, I'd try to look for the other side or a shoulder. But yeah, hip should be fine. All right, last case, which is pretty much just kind of gnarly x-ray, which is this man who pretty much trashed his ankle. It was a mechanical fall, going downstairs, and then he at some point felt that his foot just flopped to the side. We did a great job, I didn't highlight it, but we did a great job cutting off the shoe, removing the sock, getting really good exposure of the foot. Fortunately, there was good PMS. We immobilized it. Awesome. I think we need fentanyl. Yeah. So there's fentanyl. So great job in all of the above. Got to the ED, and here's what we're dealing with: a really pretty gnarly fracture. So you have fibula, you have some distal tibia, you have some widening here, which all is not happy. And then on the lateral, the sideways view, you can even see that the displacement and the alignment is not where it should be. This essentially, this all should be like kind of equal space around, and this is pretty wide. So this is even based on the way that they describe kind of the flopping to the side. This is something that's going to need surgery, and lo and behold, it is. But they were able to get that fixed up really nicely for us. So that person should do well. Obviously, it's a little bit of a rehab course, especially at their age, but that ends up hopefully doing pretty well. So. All right, I think that's all that I got. Thanks to Lauren for looking up a couple of those cases, getting some pictures for us. Any questions, comments, concerns on any of those cases or anything in general? All right, well, thanks everyone, and thanks everyone online. See you soon. Thanks, Don. Yeah, you got it. Did that work?